Today's topic is going to be new terminology and new ideas for sports-based practitioners. So we are talking pretty much the guys that are on the cutting edge is who this one's built for. So if you're an athletic trainer, this one should really ring true to form. I think you're going to like this one. I actually built this seminar for my athletic trainers. We're going to go over a lot of stuff, and why I'm so adamant on terminology is I think terminology directly influences the evolution of our professions, right? This is such a big deal to me that I think the reason chiropractic was historically kind of frowned upon wasn't so much from what chiropractors were doing, it was the fact that we chose a poor term, right? We used the word subluxation to describe our main thing that we did historically. So if someone came into my office and they had the upper vertebrae in their neck slightly out of place and was giving them headaches, I would say they'd had a subluxated C1. Now you call a neurosurgeon and say we've got a guy in an office on the corner down the street that has a subluxated C1, he already has 911 dialed. That's a medical emergency. It's huge. So terminology for me, when we get these right, it just gets a much better understanding across broad-based fields. And if you haven't got that point yet with the drchadpeters.com website, I'm trying to bring all these fields together. I'm done with these being split up into different professions, and I think we all need to start coming together because so much of what we do is in the gray area. I mean, even our professions themselves are splitting up completely. There's probably 20 different versions of chiropractors, and I don't even know what the guys on the street are doing sometimes because it's so much different than mine. So let's get into some progressive terms that I like and why I like them. And I'm really big into this whole idea of the Chad knows and the seminars that I want to do and the lectures I want to do of cutting the fat out of here. So let's just get right into it. The first one we're going to do is called on threat. I love the term on threat. It's being used in the sports world a lot more, and I want you to use it. So check out the video of Dr. Salazar walking in here and playing the patient that has a tight lower back. The guy's dying. He is on threat. Now recall, if you haven't gone through it, I'm very big into tight muscles. Doesn't mean that something has to stretch. There's basically 4 reasons why you are tight, and there's more, but there's 4 big basic reasons that you'd be tight, and they all have different applications and different treatments. So if you haven't looked at that podcast yet or gone through 4 reasons why you're tight, go through it. But basically, you have tight muscles for number 1 that are just stiff and tight, right? So you just got out of the gym, your muscles are tight. You have muscles that are elongated tight. So instead of a muscle being too short, it is too long. I think this is the most common hamstring strain, and why I'm not a huge proponent for stretching hamstring strains is because it's typically injured in a long stretch or a fast stretch. You also have tight muscles that are splinting and protecting an injury, right? And then you have electrolyte imbalances that can cause some tight muscles. So go back to that video of Dr. Salazar and he's walking in. That is a protection mechanism. That guy is on threat. His muscles are tight because he is on threat. They're not tight because he just worked out the gym and needs to stretch and use a hot tub. And they're not tight because they're elongated from an injury. The injury is most likely a disc injury or a facet injury, and the body is saying to the brain, or the brain is saying to the body, lock this thing down. There is a threat. We need to lock the body down and keep you from moving. That's my spiel. I explained to you these different versions of tightness. Now, as we're talking new terminology and also new ideas, I have an intern in here that is so smart. She said, you know, the funny thing is, when you give the patient the spiel, they get it. When you just get right into treatment, they don't get it. So for you of my guys that are the on the floor, on the ground practitioners, let me tell you something. If you are expecting your athletes to do what you want them to do, you better be able to explain the spiel like that. If they have an on-threat lower back, like the video, and you don't explain to them the 4 different reasons why they're tight and which reason they have, they're most likely going to do the wrong thing or be so scared they're going to do nothing. So again, on threat. I want that to make sense to you. I don't care where your injury is. When it's in the body's response is, oh crap, something is wrong. Let's lock the area down so it can't move as quickly or as fast or at all. So on threat in an ankle might be severe swelling and edema. On threat for the spine is rarely swelling because there's way too many body parts and too many nerves going to important organs in that area. The on threat for the spine is usually not edema. It's almost always locking the muscles down tight. And this is such a big issue that I think this is where the majority of the mistakes are made in my profession and in a lot of sports-based professions. Because we like to use palpation so much, it's very easy to feel someone's low back and say, oh my God, you got tight muscle. And if you don't understand what you're dealing with and how the body works to a certain threat at a certain body part, you're going to be doing something wrong. So get that idea of on threat. Athletes tend to love that term. It really makes it hit home for them, so they're not just doing stuff from the 1990s like stretching everything. Moving into the next one, which kind of goes along with it, it's hot areas, right? So I had a brief internship at the NFL type, with the NFL. And basically when those guys would come in, you would never want to use the word disc for a high-level athlete, right? So if someone comes in and they've got the low-grade traditional disc strain that happens to everyone, you don't say to an NFL multi-million-dollar guy, hey, man, you've got this disc issue. What we'd basically say to the athletes there was, hey, man, you got a hot low back. Don't worry. This thing will take a week. You're going to be fine. Now, when the athlete walks out, we would all look at each other and be like, disc strain? Yep, disc strain. So use that area hot. I also like the term hot, especially when it relates back to the video of Doc walking in like that, because when it's hot, that tends to click for a patient or an athlete that maybe I shouldn't be using my car seat heaters. Maybe I shouldn't be using a lot of massage. Maybe I shouldn't be sitting in a hot tub for hours at a time, right? So I like the area hot. It works really good. And you guys, I'm not telling you that these bigger issues don't happen. What I'm saying is when you deal with athletes, these different terms will help calm an athlete down so they're not so freaked out. Remember, there's 4 reasons why you're tight, and they don't all involve stretching and heating it and loosening things up. A lot of times why they are tight is because they're protecting. So if it's tight, let's just stop using the word tight even. Let's use hot. Let's use on threat. Let's use elongated. Let's use shortened. Let's use electrolyte deficiency. Anyway, that's my take. That's why I wanted to start with the hot muscles or the hot area and the on threat area. Let's get into some other terms that I love. I love the terms upregulation and downregulation. Now these are fairly old terms that are starting to really come back into vogue, because what's happening is we're all starting to figure out this idea of, let's use like the most common one, the glutes, right? Someone has glutes and they're just not active. The patient isn't able to get their glutes working, so they're having all kinds of low back issues. So what I see is 5 years ago, no one ever talked about the glutes. I remember Tiger Woods just got bombed on the Jim Rome radio show when he said, well, I couldn't activate my glutes. I had to bail out of a tournament. And we all laughed. Like he even made it like a little meme. He made it like a sound bite. He used that, I can't activate my glutes. I can't activate my glutes, over and over again. Well, now that's common terminology. We all laughed about it a few years ago, but now we all use that idea of glutes not being activated. But what I see happening is we tell people, hey, you've got weak glutes. Now, if you get one of my NFL athletes down on a table and they have got the greatest glutes you've ever seen in your life, these guys can squat 400 to 500 pounds, sometimes more, and you're going to tell an elite level athlete or a college athlete or a high school athlete you've got anything weak, you're out of your mind. They don't have anything weak, it's just not working the right way. So let's get away from the terms like it's over strong or over tight or it's weak, and let's start using this upregulation, downregulation. So for instance, if the glutes aren't working and they're kind of offline or they've lost motor control, the way you fix it is you do upregulation. If you have a muscle that is spasmed and tight, you would want to use downregulation. And that changes the terms. Now, I didn't include a foam roller on this picture, but I used the Hypervolt because that's hot. I used all those metal tools and I used your hands. You can use the same treatments and the same options for both upregulation and downregulation. What they're finding, and it's from athletic trainers out of San Diego State, and a lot of it's with the Rock Tape group, is it's all about the timing and the application. So take like the thumper over there. If you want to upregulate an area and in essence like turn it back on, it's 30-second application. That same application, if you want to downregulate, is from like 2 to 5 minutes. And it gets a little deeper than all this, and if you guys want to break all these individual terms down into like sessions that I put on there, we can do it. But I'm not going to get into how you do the treatment so much today, but the terminology you want to use. Let's start using upregulation and downregulation. I think you're going to get a lot more out of that, and I think that athletes tend to, it's just modern and it's concise and it explains stuff. Next one we're going to get to is nerve decompression. And I see this especially with cupping. Now, if you look at Cameron here, you can tell we use those little silicone cups. We're not using the big glass cups that pump up in here. When you use the great big glass cups, which are still fine, we still use them in our clinic too, in essence, you're trying to work more Eastern medicine, right? So to me, those glass cups were invented and have been used for thousands of years, not for Western medicine. They're trying to free up the chi, the energy system in the body, and I don't really understand that because I wasn't trained that way. I was trained with Western medicine. What we see the most results with the cupping with isn't even a fascia reduction. What we see it with is nerve decompression. So recall that we have way more nerves for pain in the skin than we do deeper into the body. And those nerves tend to come all the way out, and they're cutaneal nerves, and they attach just at that layer underneath the skin. So if you use a small cup and you lift up on it and the pain instantly goes away, you haven't fixed an injury. What you've done is you've decompressed a cutaneal skin nerve, one that's responsible for pain, and there is no longer a grind. The way I use it in my office is I grab my t-shirt or my polo shirt or whatever, and I put my finger underneath it, and I say, if the nerve is sitting between the muscle and the skin, and we lift up the skin, and it decompresses a nerve, and you no longer have pain, that tells us something. That is a nerve causing the pain, not an injury. So things like the rock tape, kinesio taping, light cupping, not like great big purple hickeys all over your body, but light cupping that's done quickly in a matter of a couple seconds, it really tends to work. Now, when we're talking cutaneal nerve stuff and we're getting into this nervy issues of pain, we're getting into some pretty deep stuff here. And like I said, this is supposed to be a brief terminology one, but we do have to then hit motor control next. I have a great YouTube video that we'll link onto over here for motor control. You guys need to see that thing. Motor control is basically how your brain controls a certain muscle. And as much as I didn't want to dive into motor control, and I really historically haven't used it a lot in my clinic, it's just a bigger issue. I see it all the time. It's becoming more pronounced. It was always something I kind of relegated to like elite level athletes and trying to get the last 1 or 2% of performance out of them. But I see it. Let's go back to the upregulation, downregulation. What if you've done all the stuff the right way and you still have an athlete that cannot flex their butt the right way? They cannot gain control of it. Well, it's probably a global motor control issue. So go back, learn your motor control. It's 3 steps. It's super easy. Try it, and you'll be amazed at how much progress you can make quickly getting into these injuries and starting to treat some. All right? The next one's going to go a little deeper, guys. This one takes some explanation. It's tough. But I have started using the term smudge versus focus a lot, and it's going to take a brief explanation here. This is a homunculus, and the homunculus is basically your brain's representation of what you are, right? So we have way more nerve endings in our skin, in our fingers. We have them around our mouth and our lips. I know if they had reproductive organs on here, it would be huge. And the idea is if you have an injury to a certain area of your body and your body gets blasted with new information, the homunculus is no longer in focus. All right? So the term that they're using with the industry for these guys is smudged. And I think it's a good idea. It's like if you had a picture of that and now, well, I'll tell you how they're using it. The best way I've ever had it explained. Think of like the guys that are coming back from the wars and they've lost a body part, right? An IED hits them, it blows off their arm. And now they come back and like, why do I have arm pain still? I don't have an arm there. Well, they had a tremendous, explosion to that area. The body got blasted with new information, and now it's not receiving the signals like it likes to. In essence, your homunculus, your brain's view is smudged. And what the brain does as a protection mechanism is it fills an area that it's not sure, that it's not getting good nerve control. It fills that area with pain. That's a very safe way to protect it. If an area is in pain, you can't move as fast. You can't be dramatic with it. You can't go do cartwheels down the aisles of a theater when you're in severe pain. So the body tends to fill an area that it's not getting good information from and smudges it in your brain. In order to fix that, you stimulate that area and bring it back into focus. So what they're doing with those guys that have lost body parts is they're having them look in a mirror and they're using something scratchy, like a plastic tool or really scratchy. Sometimes they'll use like blankets or little like exfoliating towels and different tools to try to stimulate that area. The idea is pain signals travel about 2 miles an hour. So let's say I have knee pain and it's not responding to traditional therapy. And it's not a knee pain that when you test it, it fails an orthopedic test. It doesn't cover one muscle. It's not like knee pain to the VMO. It's covering the entire knee. You're covering like 15 different body parts, 15 different muscles, different joints. So you start thinking, man, I wonder if it's just a pain thing. So if the brain is smudged, you want to bring it back into focus. You start stimulating the area, the brain gets more information, and it gets more into focus. That's what you're doing, and the pain goes away. So that's one you can look at. That stuff's really deep. It's really fun. It doesn't work for every issue, but it works quite a bit. Now I want to go into some old techniques that are being resurrected or being used. And you guys know I love ice. I love the ice. I think you have to treat inflammation with it. I know there's a lot of stuff still coming up with ice. I know there's crystallization that happens in the muscle and the body parts, and they're worried about that. I'm telling you, if you have a superficial area and it's inflamed, ice is your way to get it down. In the absence of ice, it's just a slower process. I still love hands-on stuff. I know we're in the world of tools. Man, let's use Graston tools. Let's use gua sha tools. Let's use voodoo bands and tack balls. And nobody uses more tools than me, guys. I love the tools. I just think they're cool. They're progressive. They keep you modern. They keep it fun for us as practitioners. But there's still a huge need for more hands-on. My warning for you guys is don't turn into someone that's all about tools and you never use your hands anymore. Hands-on people makes a difference, and there's a ton you can do. I can do up regulation with hands. I can do down regulation with hands. I can do fascial control and brain, I can do all the smudge technique and the focus technique with the hands. You can still use that stuff, so use it. That's what we're the best at. That's what our careers are geared for. I still like EMS. Now, the EMS is kind of going out, so you can tell I even tried to find kind of an older looking machine. I get it. It's been around for a long time. Here's my deal with the EMS. It's a passive therapy. You don't have to sit there with somebody that's on it. The other reason I love it is because athletes love it. They'll always tell you they like the feeling. Now, if you're one of those therapists that just crank it up as high as they can take it, that's wrong. Even the most basic machines typically have 6 or 7 different types of wavelength you can run, and each of those wavelengths do different things. So if they've got an inflammatory condition, run high volt or run one of the ones that's built for inflammation. If you want to use Russian stim to make a muscle contract, use Russian stim. If it's a pain thing and you want to try to modulate pain, use TENS. But don't take a TENS unit and tell someone they can crank it up as high as they can and that it's doing the same thing as Russian stim. Just because a muscle is jumping, it's not. If you need a review on different EMS applications, then get to it. Now, there's one other reason I still really like the EMS, especially from the chiropractic, physical therapy, athletic training world, is because once you have mobilized an athlete and got the muscles in the right position and everything is exactly how you want it, you can leave that athlete or that client there for 8 to 15 minutes without having different influence. If I'm working on a plantar fascia issue and I just got the foot where I want it, the fascia sliding and gliding, we got the joints in the right place, we got the peroneus released, and everything's doing what it's supposed to do, and you put them in crappy shoes and send them right out the door, within seconds you have undone what you just spent 20 to 30 minutes doing. And I think you get a really positive response when you can keep an athlete or a patient there in the same position. So the brain starts to realize, okay, this is the new way. This is the way we're supposed to be. This is the way we're supposed to feel. I think that is why I use it still more than anything else. Next one we're going to get to is the Kinesio Tape, the Rock Tapes, the K Tapes, the Kinesio Tapes. There's a million different brands. When I first started learning this stuff, it was all about the application. And if you move it from the origin to the insertion or from proximal to distal, it does different things. It makes a muscle turn back on or it makes a muscle release. I don't think that's what's probably happening now. What I think's happening is that tape is coming off the backing on a 25% stretch, and now you are getting a skin compression, and you're getting a lot more nerve decompression. So the guys at Rock Tape are the ones that have put a lot of research into this, and you guys would be happy. They're using athletic trainers to do the most of the research, and they're really smart. The presentation of it's fantastic too. I would strongly push you to check out one of their seminars. But what they're finding is as they were doing their research, it's not so much about the application. It's not making the muscle stronger or weaker. It's not giving you support. This is the anti-support tape, right? It's built to move. What's happening is you're stimulating the skin. And the skin is where everything's happening at. It's our biggest organ. It has 90% of our pain receptors there. Start to mess with the skin. So I still love Kinesio Tape. I still love the rock tape. I don't like it when I come across a therapist and like, oh, that tape just doesn't work. No, that tape works fine. It just doesn't do what you thought it was doing, or you don't want to spend the money to get it, but it works. Moving on. We as professionals need to start speaking better. That's what this entire, YouTube blast was for. So let's stop the scary terms. My one I see the most in my office every day, and I fight it, is the partial tear. I was doing career day today with a bunch of 6th graders, and they said, have you ever seen a partially torn ligament in the ankle? And I said, yeah, we call it a sprained ankle. How long ago did it happen? Well, like 3-4 years ago. Honey, you're healed up. You don't have that anymore. Well, how about a partial tear of a rotator cuff? Yeah, that's called a strain. Like, we've fixed those things too. So, as a doctor, I think it's all about how you present these things and what your population you're talking to. If I'm talking to a radiologist and we're trying to figure out what's going on with the rotator cuff, I'm fine with giant 50-cent words, right? Partial tears, full thickness tears, grade 1, 2, 3, it's at the insertion, it's going through the tendinomuscular junction. That's fantastic. But when you're talking to your pole vaulter and you tell them they have a partial tear in their supraspinatus, they may never come back to the full capacity they had to do it. That is a scary term, and it gets in their head. They don't tell their friends they had a strain and it's going to be fine in 2 weeks. They've got a partial tear. And if you've never told them that that's going to heal up, they assume 20 years later when they come and see me as a 40-year-old weekend warrior athlete, they still have that partial tear. And if you don't think it's true, I see it every day. Everybody that comes into my office on a new patient checks the box, I have a partial tear. The other one that I don't use a lot is herniation, annular fiber tears. We tend to use the word disc strain, disc torsion, hot disc, an on-threat disc. I don't care what you use, but I tend not to use those words. It's not that it's not happening. It's that 90% of the planet has that at some point in their life. So taking someone that just hurt their back and they're 60 years old and say, hey, you got this herniation in your disc, they may have had that. I mean, I've got a disc bulge. I've had it since I was in my 30s. I did a very heavy workout yesterday, and if you went and shot an MRI on me today, despite me feeling absolutely perfect and getting ready to go do another great workout, it'd have a disc bulge. You gonna tell me I've got a herniated disc still? Not a chance. Moving on to the stenosis. So this is one that I didn't see a lot until I had a lot of my Asian radiologists that I'm working with. And these guys are great radiologists, but they were trained a little bit differently. So stenosis to me is like bone growth, right? So you're looking at the hole that a nerve would go through, or your spinal canal, and that means the hole has got smaller. What I saw with a lot of my Asian radiologists is if it was a disc strain and they had a lot of inflammation in that canal, or even they had a small bulge in the canal, they were still putting that down as stenosis. And it was kind of confusing me, and I called them up and they're like, well, look, the hole's got smaller. There's a disc bulge that's pushing back into the canal. That's a stenosis. And what I told him is, well, as this thing gets better and starts to heal, there's going to be less inflammation. There's going to be less of a bulge. The stenosis will get less. Oh yeah, man. No, it can rectify a little bit. Well, okay, that's good. That's good. Now we're talking the same game. So I wouldn't relate that to patients. And when they come in and give me an X-ray or an MRI that says they've got stenosis, I immediately want to look at that and say, hey, are we talking like a temporary one? Does that make sense to you guys? I hope so. The same things with arthritis. When I moved down here to South Texas, arthritis was looked at as like this disease. It's like melted candle wax bones, and you've got all these spurs, and it looks like stalactites and stalagmites. And when you, as a doctor or a therapist, say someone's got arthritis, that's what I think the population down here tends to think about. Where I grew up in the north, I never really thought about that. Arthritis was just like joint inflammation. So if you've just landed as a football player, you went for a long bomb, you landed on your shoulder and it got jammed up in there, that's like a temporary arthritis, right? You've got this joint inflammation. It'd be like how we look at tendinitis or tendinosis and that kind of stuff. We didn't look at it as like a disease. So let's stay away from the disease stuff. I think we've all kind of got to that point where no one really calls it Osgood-Schlatters disease on the tibial tubercle anymore. We just call it tibial tubercle inflammation or irritation or patellar tendonitis, all that stuff. But when you use these named conditions and diseases, it really gets in patients. It really does. I get tons of ankle stuff that comes in here from young, like 6th graders, and like, oh, my family pediatrician says we got this disease in the ankle. I'm like, oh my gosh, man, you've got like your Achilles is tight. Like we can work on this stuff. That goes back to my picture of using the spiel. And whenever I get a chance to use a Jewish Yiddish word, I always do it. So you can tell I picked spiel instead of spiel. It's the same thing. Explain this stuff to patients. It takes the scary away. Guys, that's pretty much where we're at. I'm going to leave you with the last slide. Terminology is all about relaying knowledge. And you can use better terms depending on who your clientele is. You don't need to scare people, and we definitely don't want to scare our elite athletes when we're in the profession. We're the employees. They are paying us to make them better. Let's not use terminology that scares them and affects their performance. We're built, and our passion is in improving performance. So don't do these little things that is hurting their performance. Terminology conveys information easily, and it makes for much better understanding. And when you have the understanding, when you've gone through the spiel and you've used terms that athletes dig, it drives patient care, and it drives the treatment when you're away from their practitioner. Let's go back to the very first video, the one when Doc came in with his tight back. If that's one of your athletes, and we all see these, and you just say, hey man, you've got tight muscles in your back. When that athlete gets home, he's assuming he's got tight muscles. He's stretching it and foam rolling the crap out of it, or having his buddy use some of the tools they got and just mashing it because they assume it's tight. We need to stretch it because that's what they were taught from their coaches. That's what we were taught from our coaches. That stuff is 1990s. It's 2020 now. It's time to get on with the new stuff. I hope you like this. Any of these issues I'd be willing to dive into a lot deeper. This is where I started out. I hope to get a great big conversation with this one on the bottom. Let's start talking terminology. You guys send me what you have. Send me the words that you use, the things that you've seen that have worked in the office.